Hello there, and thank you for joining us today. My name is Melanie Elliott, and I'm a regional director at Benefits by Design, servicing the York, Dufferin, and Simcoe regions in Ontario. I'm pleased to be joined today by two passionate and knowledgeable advisors. Dave Patriarche, President of Mainstay Insurance, and Jeremy Stakov, Employee Benefits Consultant at Sphera, who will be taking two sides on the hot topic of National Pharmacare. Just a couple of notes before we get started. First of all, this is going to be a structured debate on the topic of National Pharmacare. Dave will be taking the stance of being for pharmacare, while Jeremy will argue the opposite. Both speakers will cover the overall pros and cons of the issue, and I want to stress that the purpose of this webinar is not to sway you one way or the other, but instead to broaden your understanding of a very complex and potentially impactful issue affecting our industry. Secondly, this webinar is being recorded. You'll receive a follow-up email with a link to the recording after the webinar. If you have any questions or concerns about the webinar, please contact us at socialmedia@bbd.ca. We'll be running a question and answer session after the main presentation, so stick around. There's no such thing as a silly question, so please ask away. If you do have a question, please type it into the GoToWebinar question interface, and we will do our best to address them at the end of our webinar. So without further ado, let me welcome Dave, who's going to kick things off and introduce himself.
Hi, Mel, and thank you very much for having me here. For those that don't know me, I'm president of Mainstay Insurance Brokerage. I've been an advisor since 1996, and I do nothing but employee benefits. I think, maybe one of a handful of advisors in Canada that is totally specialized, so no individual products, no top-ups, carve-outs, and everything else. And I also do no pension or retirement products as well, so strictly small group benefits. And most of my clients are under 100 employees. My target market is probably kind of 2 or 3 to 50. I have some that are up in the hundreds, but I really kind of prefer the smaller ones. And back in 2008, we started what is now called Canadian Group Insurance Brokers, which was a loose association at the time, and that's become more structured over the years, of advisors across Canada. And it was set up to help share information and help advisors. And through that, I've learned a ton from all the different members. And I'm also a member of the Sanofi Canada Healthcare Survey Advisory Board. And with that, it allows myself with some of the consulting houses, some of the largest employers and union groups across Canada to get together and take results from surveys of both employers and employees and find out about what people think about Canadian healthcare and benefits. So it's a great education tool for me being part of the survey. And what you see as the final result is just kind of a summary of the information. There's actually a ton behind it. So it's kind of a neat part that helps me understand the marketplace a little bit better and stuff as well. How's that, Mel?
That was excellent. Thanks, Dave.
No problem.
Glad to have you here today. Let's flip it over to Jeremy to introduce himself.
Great, thanks, Mel. Thanks very much. Hi, everybody. To introduce myself very quickly, my name is Jeremy Stakov. I'm an employee benefits consultant with Sphera. I've been a licensed advisor since 2014 and work mostly in employee benefits and do a little bit of retirement plans as well. I mainly deal with startups and restructuring plans that are maybe not performing as well as they should be. But before I was a consultant, I actually worked with insurers for over 6 years before moving into consulting and working for employers, which really gave me a unique perspective. And while I'm not part of the Sanofi board like Dave, I have worked with carriers as underwriters, account manager, and an account executive, which gave me the opportunity to learn about benefits plans and how they run from the inside out before moving out to help employers with their plans.
And
Amazing. Thanks so much.
I think that's an amazing thing. I wish I'd had that experience because it does let you see both sides of the coin. So it's got a lot of value.
Absolutely, yeah. Great to be here.
So to get started here, Jeremy, why are you against National Pharmacare?
Well, on a very high level here, I'm concerned with rollout and coverage gaps. Access to medicine and shortages. What happens if timelines are missed? I mean, we've all seen government rollouts and new programs in the past. They're not always smooth. Often timelines are missed, if not pushed back. And what happens when these timelines are missed? When we're talking about maybe yours or your mom or your dad's or another family member's prescriptions. Citizens need access to their prescriptions when they need them, and I'm concerned about these gaps that may come out when timelines are missed and it's not rolled out properly. Another concern of mine is cost to taxpayers. $34 billion in prescription meds is what was spent in 2018. Now, are we really going to cover all of this as taxpayers? Not to mention the financial and economic impact. With 38% of Canadians being covered by employer-sponsored plans, this works out to about $13 billion taken out of the industry and economy. Now, this will result in job losses, possibly business closures, and allow, in my opinion, the big guys to swallow up the small consulting offices. I mean, what happens too if you lose 25% or even more of your revenue at your company? Is everything going to stay the same? I wouldn't think so. Now, lastly, we already have experts in place that know what they're doing. We don't have to change the effective distribution system that we have and transfer everything over to the government. We can still have a lot of the benefits that are being promoted without reinventing the wheel. Now, with a new formulary that is maybe applied nationally and supported by the federal government, including the recommendations made to negotiate drug pricing, we can have, again, most of the positive outlines without removing billions, maybe tens of billions of dollars from the economy. Now, I'm all for applying many of the theories outlined in the report to improve the system. I mean, who wouldn't want to improve it? But again, why change the distribution channel that has been working so well for Canadians for so long and jeopardize insurance industry jobs and businesses in favor of letting the government take control of this? In my view, drug prices are the problem, not the system. And we can work with the government on this issue without having to reinvent the wheel.
Excellent points. Dave, why are you for National Pharmacare?
For all the same reasons that Jeremy is against it. So in a way, a lot of this stuff is just double-edged swords. Right now, we have huge gaps in coverage and inconsistent coordination between the provinces. There's drugs that are covered in BC that aren't in Ontario and vice versa. One of my favorite pet peeves is the insurance company's refusal to coordinate with the Trillium Drug Program in Ontario. That's a huge problem that's causing employers over $100 million a year in costs that are really actually supposed to be the provinces. So we've got these gaps and employers are being unnecessarily loaded with the costs. And I think that's something we've got to get rid of. We as Canadians see healthcare as being, portable and consistent from coast to coast. And it's really not that way when it comes to drug coverage. And when it comes to cost, the cost is already out there. We're not talking about additional expense. We're talking about changing the expense, taking a portion off of the employers and also a portion off of employees that are cash paying and moving it over to the entire population. By doing so, if you remove advisors and insurers, which makes up roughly 20% of the cost, you really reduce costs a lot and still are delivering the medicine even before negotiating drug prices. So I think right away, we've got an opportunity to save money by removing layers of coverage and working with a model that the provinces already have in place. In Ontario, for example, the ODB program, although not perfect, and I agree with Jeremy, there's lots of areas that we can improve, and drug pricing is just one of them. But the ODB program works pretty well. All we have to do is take off the age test, take off the, you've got to be over 65 to be eligible, and you've got full delivery, very quickly and affordably. And I really think that we need to see the savings on plans and drugs specifically, because we're talking about it here, to be able to invest in new treatments. So just like we've seen drugs go on to generic drug options when they've fallen off the patent cliff, then you have all this extra money to create more headroom to pay for new treatments and new drugs along the way. So I think that savings would be reinvested in other areas. And a lot of people don't have access to the information or products to really protect their employers and staff. Jeremy's right. There are lots of experts out there that know how it's done, but there's a lot of people who don't have access to those experts. And whether it's just poor training or being in the wrong place or the wrong time or not getting information from front row practitioners like pharmacists and doctors and stuff, it's just not always possible to get there. If it's fully integrated in a system coast to coast like Pharmacare, then you can't help but getting help. And the last thing is one that's kind of a little bit philosophical to me, and that is that our license, when we're licensed by FSCO or now FSRA to sell insurance and so on, is we have to put our clients first. And I really think by trying to reduce this cost and putting it over to the the general population rather than just the employer, I think that makes good sense. I think this will come up again later on, but I've always kind of wondered, why is it fair that the employer is paying for the families of their employees' health when it isn't directly benefiting their company? So I think that by putting clients first, you kind of got to be for National Pharmacare in order to make sure it stays affordable and the gaps are covered in the long term. Mel, throw it back to you again.
Yeah, absolutely. I think you guys have made some great points. But what I'd love to know is, what do you think the pros and the cons are from the advisor perspective?
Jeremy, you want to jump off on this one first?
Sure, if you like. I mean, to me, again, it comes back to removing drugs from plans, and that will cut premiums and therefore broker commissions by 15, 25, 30, or even 40%. I mean, it depends on obviously the structure of your plans, but a lot of plans have 40% of that premium is in drugs. Now, if drugs are removed, will there be a place to add value? Yeah, likely there maybe can be, but we're still removing $13 billion from the group insurance industry, and that will result in layoffs and business closures. I mean, again,
Okay,
if a small
hold
office
on, hold
loses
on, hold on,
40% of the revenue, that can be devastating.
Who's going to get laid off and what businesses are going to close? Are we talking about just the insurance companies? Because I don't know. I look at my clients and I go, cutting those broker commissions, yes, is an issue and it will affect us absolutely.
Right.
But will our clients not look back and go, hey, there's other stuff we haven't touched for years. Our vision needs to be upgraded. It's still $100. We got critical illness coverage we'd love to offer but never gotten there. There's a lot of new products and services that I think clients would love to be able to add, but it's been tough when you've had the volatility of high cost drugs and things, making renewals hard to project.
Yeah, I mean, I think clients certainly want to add what they can, but I think again, if you're automatically cutting 40%, I don't see any company adding all of that money back into their plan. They're
I
going to take some
disagree.
savings, which is going to result in lost revenues.
Yeah, I do. But do you really think it'll end up that insurance companies are just going to be all of a sudden cutting people all over the place? Or do you see do you see brokerages all of a sudden shutting down because of it? I think that's kind of extreme.
Uh, Maybe not brokerages shutting down, but certainly if you're talking about a smaller brokerage with maybe 4 or 5
Yeah.
employees, all of a sudden you're losing that much revenue, and all of a sudden your assistant or maybe your account manager, whatever it may be, you just can't afford to have them on anymore. And looking to
Yeah.
the insurer side, I mean, if you're talking about claim specialists, for example, there's a lot of jobs in claim specialists for drugs that are just not going to be needed anymore.
Yeah, but let's be fair. If they followed, and this is a big if they followed the step up system, starting with essential drugs, which is somewhere between 150 and 200, and then moving up to the ultimate, I think it's 6,000 drugs or something that they were looking at. We're talking step by step, and we're also talking about the private plans can still provide coverage for the other areas that the province doesn't. So we'd be kind of pulling off just some of the basic ones, which admittedly make up 50% of the scripts, but they don't make up 50% of the price. So I mean, I honestly think that it's going to be a step into a reduction if they follow that plan and don't just do it all overnight. So I don't think the effect will be nearly that big. But I do
Well,
wonder whether there will be a big push eventually towards more defined contribution, health spending account, and hybrid plans. That's for sure.
okay, you say that, and I mean, in my block, I would say about 75% is already defined contribution.
Really?
Yeah.
Oh, okay. So mine is probably about 20%.
Yeah, so a large portion of my block is already defined contribution, so I don't see that being a big impact.
So then if you're mostly defined contribution, then when it's pulled out, do you not think the employees are just going to use it more for whatever dental vision and everything else? Like the ones that are hitting the maximum are still going to hit the maximum just on other stuff?
If those maximums are increased by the employer, or if they have the option to do so, probably. But I'm not convinced that every employer will increase those maximums to supplement the 40% you're losing from drug plans.
No, but if you have a plan right now that's got like a $2,000 health spending account or a $1,000 health spending account, and
Mhm.
the people are spending it, and you're making your commissions on that thousand, when the drugs go away, do you think that $1,000 is going to disappear, or is it just now that the dollars are, being used more for dental than for drugs, and it's going
So
to be a
let me
similar,
so let me ask you what the utilization is on your health spending accounts on average.
74%, I think it is. Just
Okay, so that's quite
like
high then,
yeah.
in my
Mine
experience.
tend to be a little bit low. I've got a few that are big, but they're not like $500. Like they're 500, 1,000, 15, 2,000 kind of thing.
Mm-hmm. Mm-hmm.
Yeah.
Yeah.
So
I mean, I don't think you're going to make up 40% on increasing your HSA. I just don't see that happening.
no. Okay. I
And, and what I
yeah.
would suggest is maybe a better option is moving to a tax incentive type of idea for companies that do invest in drug plans for their employees,
Oh,
right?
I'm 100% for that.
Why are we removing all of this from a system that already works, that's been in place for how long,
Because
and
it's
giving it to the
20% too
government?
high. Yeah, but no, don't give me that because the insurance companies know in Ontario that they're processing every high cost drug wrong. They all know it. Trillium, the Ministry of Health has made them aware of it. They know that they're doing it wrong and they're making money off of it and they're not finding a way to resolve it. There are very few players in the marketplace. There are a couple, but that are actually doing it. So kind of saying that the government's going to be the problem. No, the insurers are the problem right now just as much. They've contributed to this high cost problem in Ontario, at least, more than anybody else in the whole thing, like more
Uh,
than the pharmaceutical companies.
I'm not saying that there aren't issues on both sides. Don't get me wrong here,
No, I know.
but again, I really don't believe that the government is going to do it any better.
Really?
And
Okay.
it seems to me that
Well,
we could provide many, if not all, these advantages with little of the downside, just by changing the mechanism of or keeping the mechanism of distribution as opposed to changing it all.
But are you willing to drop 20% and your commission and everything else and keep running it through with no cost? No, but
Say
the
that again.
government will. Like, would we
Uh,
just remove our commission on drugs? Would the insurance company remove their portion? No, not a chance. They're making too much money on it. Just saying.
let's move ahead to the taxpayer perspective and talk a
Sure.
little bit about that. Do we think the cost is too high? How can taxpayers handle the extra expense of paying for these drugs? Dave?
Yeah, it's not extra expense. The expense is already being spent. We're just talking about who's paying it. So instead of it being concentrated to a great deal, I mean, there's public plans like the seniors, but we're talking about private plans. So instead of just concentrating it on the employers paying it, we're spreading it more evenly across the entire population. So it's not like this is an extra 34 billion. No, we're pulling it off of one side and we're sharing it amongst a bigger pot. So is the cost too high? Sure. And I think Jeremy and I will agree there's like tons of stuff that we can do, whether it's a PMPRB pricing, whether it's negotiations or whatever that can bring drug costs down a bit. But bottom line is the cost is already there. It's not a new expense.
I'd have to disagree that there's no new expense. I don't see how the government can just pick this up without any new expense or any new people working on it or anything happening in the background.
Really? You think the government can't do this more effectively than the insurance companies and the rate that they've been dealing with it over the past years? When we have
Yeah.
distribution systems like RAMQ in Quebec, BC Pharmacare, us in Ontario, I mean, the model is built. It's already delivering for a huge portion of the population. Where's the extra people come from? Most of it is administered in Ontario. The Ontario Drug Benefit Program for seniors is run by TELUS. So I mean, it's a big computer model that's doing the funding. I mean, yes, there's customer
Right.
service people, but you could take the people from the insurance companies and hand them over to the ministry, and you'd be neutral
So
as
here
far
we
as
go.
staffing.
But so that's exactly the point then. You have to take all these people from one place and put them into another for it to be even. And I don't see that. I just don't see that happening on an even
No,
split.
and it shouldn't be.
It won't be one for one.
No, it shouldn't be because it's already too bloated
Right.
in the wrong places right now. I agree 100%. There will be losses and that will be cost savings to the taxpayer. I agree with you 100% on that.
Mm-hmm.
So I don't know. I mean,
And I mean,
can they run it? I don't know. I mean, you're 100% right. There's lots of examples of the government running poor programs and stuff, and we
right.
can list them forever. But I have to say, and I mean, my experience is mainly Ontario. The Ontario Trillium program, although clunky, works pretty well, and the ODB program works actually really pretty smoothly for most people most of the time.
Yeah.
Not everybody all the time. I agree.
Let's add one example of that though, of OHIP Plus.
Okay, so a
We could look
one-year
at how
initiative.
faster. Right, a
Okay.
one-year initiative, which sounds very similar to this National Pharmacare to me.
Yep.
What they're trying to do, right?
Sure.
Put this new program in, get it going, get it running. Oh, don't worry, it'll all be good. We'll fund it. It'll be easy. There'll be no
Yep.
changeover. It didn't happen. It was a complete failure because nobody understood it, and it was rolled back after a couple of years. And
Okay,
if
but
that
that was
same thing happens here with National Pharmacare, I have huge concerns.
Okay, so the only and you're right to have huge concerns. The only reason it was rolled back was political. It had nothing to do with a lack of efficiency. The Ministry of Health, I think, actually did a great job. I mean, it was rushed through very last minute, and the insurance companies and everything moved as quickly as they could to integrate. And I'll give everybody credit, whether it's the ministry or the insurance companies dealing with it. And I mean, they had gotten past the hump of the problems in getting people working. The biggest problem that came out of it was stopping it again, and that was political. That wasn't a failure of the program. I don't think
And,
that's fair, but
and what
yeah.
happens if National Pharmacare becomes politicized?
Good point. Okay, I'll give you that one. But I mean, but what do you, I mean, that's like saying, okay, next year, all of a sudden the provincial government's going to stop hospital funding. Yeah, totally possible. But I mean, we're hoping that there's enough incentives from the federal government to the provincial to make, the whole thing go. And I'm not convinced that's going to happen. Like if you ask me right now, do I think pharmacare is a foregone conclusion? Absolutely not. In fact, I think the chances of it going ahead are about 1%.
Especially on
And
the timelines they've given.
yeah, some of the timelines they could pull off because a lot of it's actually the work has already been done. But the reason I just think how they rolled it all out and how the government distanced themselves from it would indicate that this is not going to be a key part of their policy going forward. But that said, there was just recently a survey done by, and I mean, for as much as you follow surveys, by Environics, and 93% of people across Canada polled think it's important for everybody to have equal access to prescription drugs, and 88% thinks the federal government should be doing that. So that's just out a couple days ago, and they reiterated a bunch of questions about, have you ever had problems with paying for costs and stuff like that, and those issues kind of come up over and over again. But I mean, it was something like 9 out of 10 people thought a national pharmacare program, regardless of income, was a good idea. So the taxpayers don't want to pay for it, but they sure like the idea of the program.
Right, and I think as Canadians, we all like the idea of the program, right? Everybody has equal
Sure.
coverage. It's the implementation of it and the rollout of it that I think has a lot of us concerned.
I agree. So let me ask you this. If we could just solve the implementation and rollout, then would you change sides and say you're for it?
I would be much more open to the discussion.
Cool. Okay. So the other question that is on here is, will costs skyrocket with the government running it? And I really don't think so, because the distribution model is already there. You're right, we have ours built, but they have theirs built too, and they've been doing it for a long time. BC Pharmacare is seeing costs rise like crazy, but I mean, it's more just because of the cost of drugs and the program and everything else, not so much, I don't think, from the administration, from the information I have seen. But I mean, I guess, at the end of the day, that is the concern, and costs will jump as we go from the introductory short list to the mid list to the full list, over the coming, whatever it is, decade.
And you have to assume that there will be an impact to taxpayers, to the individual taxpayer.
Oh,
There has to be.
100%, 100%. So instead of an employer paying on average, let's just pick a number, say $2,500 per employee per year for their benefits, that number is going to drop, and instead every Canadian is going to pay, $500 more or whatever
Right.
the amount is to cover the plan. And I would say, is it that much different than anything? But hey, let's use another provincial thing, education, where you have everybody in the population paying through property taxes towards education, even if they don't have kids in school. Well, no, it's because you were a kid, or you did have kids, or you will have kids. So everybody's contributing to the bigger pot because it's better for society. I think it's very similar to that.
As long as it's run efficiently, I suppose.
There you go.
Absolutely. Now let's move ahead to the insurer perspective. So we've provided this coverage for decades. Some might say it works well. So why change this system? Jeremy, you obviously don't want to leave it status quo.
I do, yeah. Having worked there for a while, again, maybe I'm a little bit biased, but I think insurers do a great job of covering everybody, making sure that employees and citizens have the coverage that they need, have the prescriptions they need. And again, if we're removing drugs from every plan, that's a lot of lost revenue, and it will lead to job losses, which will further impact the economy still. I'm not saying that everyone should be guaranteed a job, of course not. But I think I touched on this before. It's difficult to tell a claims specialist or a customer service rep or any employee for that matter that they're going to lose their job because of a government decision to take over a functioning private industry. And to me, that just doesn't make sense. I mean, we can also talk all day about the trickle-down effects of lower employee morale, increased workloads with less resources, all the rest. And I mean, insurers are certainly not perfect, and I'm sure we could find a lot of efficiency through technology and other investments, but with significantly less revenue by removing these drug plans, these investments are going to become even more difficult.
Are you kidding? Like, seriously, like the insurance companies have systematically increased cost on drugs rather than trying to find ways to save money. So the PBMs have offered to the insurers that, hey, they can go out and bulk buy on behalf of all their clients and get savings. And the insurers have said no. The provinces have said, hey, we'll pick up more of the costs if you'll pass them to us. And the insurers have said no. And we see it kind of time and time again, a lack of investment in infrastructure, specifically computer systems, to really adjudicate claims well. One of the big consulting houses just pulled out a thing where they found that one of the PBMs is paying generic drug claims wrong. And it's been going on for years, and they're just getting around to fixing the problem years later. Well, that's all been at the cost of our employers. My clients are paying this bill year after year, and they're having to make changes and to plans and be the bad guy because the insurance companies are not stepping up to the whole thing. And I mean, we haven't even talked about the drug companies yet, but I mean, the insurers have had the opportunity for decades to build better systems that work better, and they haven't done it.
I completely agree that the insurers need to build better systems. I mean, I worked on those systems. Working on a DOS system is not really effective in today's world. Don't get me wrong on that.
Forever. Yeah.
Yeah.
Yeah. So, I mean, I think that takes care of our other point. Does it work already? It works. It just doesn't work efficiently or effectively as it could. And
I don't think switching that to the government is going to make it any more efficient or effective.
yeah, I don't know. I mean, I don't think it'd make it less effective. I mean, and quite frankly, we've got the same problem if we got a PBM that is doing both the provincial work as the one that's also got the problem with the generics. We have the same problem on both sides. So no better, no worse, just more of the same.
So
yeah,
if it's about drug pricing, then if it's just about drug pricing, then why can't we still have the federal government and the provincial government step up and have a national formulary, national pharmacare type of formulary that's implemented across regions, across insurers, but supported by the federal government?
Oh, that's a fantastic idea. And those formularies do exist. So like, I can't remember the name of it, the 200 essential list and stuff like that.
Right.
The countries all over the world have picked up just because of what you're saying. And you're 100% right. And guess what? The insurance companies refuse to do it. They refuse to build those formularies, those limited models and things like that. And I think like me, a lot of our clients are small business. Small business choice in benefit plans is negligible. Like, I mean, we have a handful of formularies, generic, mandatory, generic brand, with or without lifestyle drugs and things like that. But I mean, for the most part, we can't do maximum out of pockets. We can't do anything revolutionary. Not even revolutionary, but something like from the 90s when it comes to choosing formularies. So we've been prevented from having the tools to do it. And part of that's a systems problem, but part of that is a dollars and cents problem. The insurance companies in my opinion, this is all in my opinion, they don't want to see less claims paid because it means less profit. So anything that would help reduce and control costs has not been a priority.
Yeah, and I don't disagree with that. Maybe that's where we need to have that government intervention to say, hey, listen, the distribution mechanism works. The way we're doing it works, but the pricing is way off. So therefore, we're going to have this formula that will be implemented across regions, across insurers, and away we go.
Jeremy, I am with you. So for the record, I support Jeremy Stakov's option to have the government regulate the insurance companies, take over the distribution, and tell them what to do. I am with you 100%. Now I'm not going to
move on from this side as we agree.
Yeah.
There you go. We're done. Okay. If we are in agreement on that one, let's move on to the employee perspective then.
Sure.
So I guess the big question that I think employees and people, all Canadians would have is, will employees and Canadians have to pay more taxes as a result of the shift of National Pharmacare?
Yes.
Yes, they will.
Yeah.
Programs need to be funded.
100%. And we're agreeing on that. I think we're taking the money from one place to another, but quite often right now it's the employer paying it. And so in part, and we're going to be putting it back to not just the employees, but all Canadian residents, 100%.
Yep.
Absolutely.
Do you want to go through a few more questions, or do you want us to just bounce through them?
Well, we're still in the employee perspective here. So
Yeah.
won't drugs be cheaper and therefore employees will actually pay less?
And I think the answer is yes. With
Okay.
Pharmacare, they will pay before any negotiations with drug companies, before the PRB makes all their changes. I think the cost will be about 20% less.
Okay.
I'm not sure I agree with the 20%, but you would hope over time with all this. I mean, if it doesn't end up being less expensive, then what's the point, right?
Oh, I agree, but do you not think it should start out sooner than later just by removing the layers? Insurance company, profit administration, advisor, profit and administration, or
We
commissions?
touched on this before. I don't think it's the gap that you're suggesting. I see what you're saying with the 20%. I understand how you're getting there. I just don't think that's going to be realized, no.
No, okay.
Uh, in terms of National Pharmacare bringing on, or could mean that new high-cost drugs will not be released in Canada. What do you think about that, Dave? I would suggest that yes, that probably does mean that that there is the potential for some new high-cost drugs to not be released.
And we're going to agree on that one as well, I think. I think there is the potential for it. I think, though, just like, generics coming into the marketplace and brand name drugs having that competition, it does create headroom for new drugs. So if we have a pharmacare plan that does see better options along the way, I think that we will see releases. Will there be some? Absolutely, that don't make it to market. And in some cases, that may be the right thing, either because they aren't as efficient or effective or
Whatever.
cost
Yep.
intelligent or whatever. But I think that there is a risk of that. Now, my question would be, if we looked in the rearview mirror, the day before those drugs were there, we still would say that we had great access to healthcare. So that one new drug being denied, does that mean all of a sudden we're a terrible country? I don't think so. I mean, if we constantly are looking to cover everything to everybody all the time on any chance of positive outcomes, I think you get to a point that's just unsustainable. So
Yeah.
I don't think sometimes not, well, there's too many negatives there, but I think the holding back on releasing on every drug or covering every drug maybe is not the end of the world.
No, and I don't think you could ever suggest that everybody should be covered for everything every time, because that's just not a sustainable model.
Yeah,
Um,
agreed.
That said, maybe that's where, if we do have that type of system, again, an employer-sponsored coverage could fill that gap,
Yeah.
right? Which
Yep.
again brings me back to having two distribution systems, and why not just keep it as one?
And I'll agree with you on that, except I have one problem with it. And that is the insurance companies have their biggest problem with volatility in claims. So in small insurance, small business insurance market, we have very little insurance because of the high stop loss attachment points, because of the high credibility on experience. Those people are dramatically hit harder by the cost of a high cost claim. And I think that we've got to find a mechanism that works better kind of across the whole board. So if we now start to take out the bottom end drugs, those most common and cost effective, and leave the insurers just to handle the higher cost and specialty drugs, then that cost for that shortened list is going to skyrocket. And that's going to be because of the insurers' inability to plan, price. There's no transparency, and we've seen what's happened with stop loss rates, where the insurance companies kind of refuse to back up what they're doing. And so what we just see is costs go up and up and up, when we've actually seen, especially like this year, costs in Ontario have stayed almost flat. Part of that's OHIP plus and not long-term sustainable. But I mean, it's not working the way it is. And when we kind of step forward through pharmacare, I think it'll be harder and harder for insurers to affordably and efficiently cover the reduced list of drugs. So maybe that's a plus for you, for your side, but I do worry that halfway there isn't going to help anybody.
Mm-hmm. Now let's touch on the pooling though that you mentioned.
Sure.
If we're talking about these high cost drugs in a national pharmacare setting, in the insurer setting, the insurer takes on that risk, right? Above the pooling to a point, minus CP3, all the rest.
No, they don't take
How
on any
does
of the
that
risk.
work in a national pharmacare?
The insurance companies don't take on any risk. Our employers do. The only risk the insurance companies take on is for their own employees. So that pooling, that risk is not taken on, because every day they have the chance to readjust that pool and put that cost back on the employers. So to say that, they take the risk, the only risk they have is if every employer shut down the plan tomorrow and they didn't have a chance to recoup, which is not realistic. So, so how does pooling work with the government? Well, let's talk about Ontario Drug Benefit Program. Let's talk about Trillium, RAMQ, BC Pharmacare. When you have a big enough pile of costs, you can be more efficient, effective in not just the delivery, but the purchase of those drugs and stuff like that. You create your own pool from the size of it, and the cost is spread amongst large numbers rather than small numbers. And what we see in the insurance side is the insurers want to anti-select against high claimers that are small companies by the plan designs they've created.
Yeah, I don't disagree that there is some anti-selection going on against high claiming smaller groups. Hard to argue against that.
There's a lot.
Yeah.
And there is an answer. And I mean, you're right. If we kept the existing model, the simple answer, not to quite go to your extreme of the government, mandating, but would be for small group to be maybe 2 to 50 or 2 to 100 to be a fully pooled product for everybody. So no claims experience, and what you do is full transparency, and you show what the pool is, and you share their cost equally amongst all the employers based on plan design and stuff. And that's how the US does it. It's publicly posted numbers, fully pooled, up to 50 or 100 lives.
Now we're talking. Yep. Yeah, that's the true spread of risk. That's what I would love to see there.
Yeah, and I 100% agree. And will it ever happen? The insurance companies are terrified of transparency. Otherwise, we'd see LTD payout rates, we'd see stop loss claims ratios, and we'd see travel coverage. So we're in agreement there too.
Yep, we agree there for sure.
Excellent. Well, on that note, with
I know,
with
right?
everyone
it's not very fun. I much prefer arguing with you.
Me too.
Where's the blood from all the fighting during this debate, guys? You agreed a couple times.
Yeah, I know. Well, we're both having bad days, I guess.
I know, we're both thrown off.
Yeah. Well, on that note, thank you to both Dave and Jeremy for all that great info. Both speakers brought up some great points, and I think it's important to acknowledge that there are pros and cons to both sides of this issue. Like I mentioned earlier, this webinar isn't meant to convince you one way or the other, but it's to open up conversations and broadly increase all of our knowledge about the issue. Heading into the Q&A portion of the webinar, we have lots of questions so far. So just before we jump in, I want to remind everyone that this webinar is being recorded, and the recording will be sent to you in our follow-up email afterwards. Please continue submitting your questions through the GoToWebinar platform, and as we go through them, we'll answer them one by one. Now, I did chat with Jeremy and Dave prior to the webinar starting, and they are willing to stay on a little bit longer if we do happen to go past that 3 p.m. mark, just because we do already have so many questions. They'll stay on and we'll continue recording. So if you have to jump off, you can always refer back to the recording afterwards. So let's jump on in here. So our first question, more of a statement or a solution, is why not cover those individuals who have never had or will never have any type of drug coverage? Group insurers could coordinate their plans with the national program to ensure that no double dipping occurs. National Pharmacare is a great thing for those individuals who are currently without any coverage.
Yeah,
Dave,
I agree.
Jeremy?
Yeah, I mean, we do have to fill out the gaps. The numbers are not as big as people think, and the survey results are really skewed on that. So people in BC, Ontario, and Quebec, for example, there's lots of people who answered they have no coverage. Well, that's just not true. There is coverage. If you're a resident of those provinces and others as well, then you have things like BC Pharmacare, you have Trillium in Ontario. It's just people don't know about it. But there still is gapping, and there still is situations where there's costs that, co-insurance levels, whatever, deductibles or maximums, where people do have large financial gaps. And I think Pharmacare will help there.
Absolutely.
I agree with you.
So another question we have here is, they would disagree with Jeremy's point about insurers eliminating large percent of claims. Staff remember that most insurers do not adjudicate their own claims, but outsource to third parties like Express Scripts and TELUS, who make their revenue from paying claims.
Well, it's good to see people disagreeing with Jeremy, because, that's just the right side to be on. But yeah, do you want to back it up, Jeremy? That, they make money on paying claims, so why are they going to basically try and pay less?
Yeah, I mean, some of them do outsource, yes, but some do pay in-house. At the end of the day, though, it's about premium, right? You make money on premium and you make money on claims. And if you're removing all those claims and all that premium, there is going to be a financial impact to the company.
Okay, so but what's the incentive for insurance companies to do it right, to do it more efficiently or effectively? There really isn't.
Yeah, there really isn't, unfortunately. I guess moral standards.
Whoa, insurance companies, moral standards, same sentence, Jeremy.
Hey, I work there. I can honestly tell you that
Okay.
most people try and do their best.
No, you're right. That's not fair. You are right. I will give you that. Hey, can we take on some? I see some questions here from Mike McClenahan. I've never heard of this guy before.
Yeah,
But can we
he's up
can we,
next.
Who's that
can we
guy?
shoot down some of those?
Yeah, sure. So we have two questions here from one of our managing partners, Mike McClenahan. The first one is a question to either, and it is, even if we accept that National Pharmacare as good for Canadians, this is highly politicized constitutional issue. How do you feel the provinces will react?
You want to jump first, Jeremy?
You go ahead on this one if you want.
Sure. Honestly, it is. I mean, it is a provincial mandate to deal with this. So I think what you have to do is, settle up transfer payments to make them kind of get on side. And I think you could do it. Like, I mean, I don't think the federal government has to change the constitution and take over the responsibility of drug care or health care. But I think overall, you could incent the provinces and basically support their programs that they have right now that they're running in a financial way to make it more effective. So as an example, in Ontario, if you took the Trillium programs, the ODB drug program for seniors, the EAP and SDP programs of Ontario, and said, like, here, we're going to provide a solution that helps to fund all that through general revenues and transfer payments, I think that the provinces could react better. Real life, the initial, I think, from Quebec and Ontario is we're not playing in this field, but I think when it comes down to the citizens hearing that your premiers are not supporting something that you support, that'll change pretty quickly.
Right. Yeah. Mike also went in here and threw his 2 cents right at Dave, saying yes, he's biased, but he believes it's naive to assume that the government can be universally more efficient than the private sector.
Yeah,
We
I
agree there,
would
Mike.
say, yeah, totally. I would say I agree too. So my challenge to you, Mike, BBD, and any insurer or TPA that's listening in is, then let's see you become more efficient, more effective, bring more pooling in, more protection for small business, and overall be able to help more Canadians. I'll push it back on you. I think you guys are up to it. I think you got to decide to do it.
Yeah,
I'm never going to be asked back for a BBD webinar ever again.
Yeah, right.
Yeah.
And I'll have to agree with you there, Dave, as well.
Yeah, perfect.
Wow, that's 5 times now.
No, right, we're doing good. We're doing good today.
Okay, so if National Pharmacare is launched and up to 40% of monthly premium is removed from benefit programs, maybe it's time for group long-term care to launch in Canada. Group home care savings accounts would give plan members flexibility in assisting elderly relatives or their own care in the case of surgery and subsequent recovery. What are your thoughts on that?
Jeremy, all you.
Yeah, I mean, why not have a system that can support citizens in a way that they maybe aren't being supported right now and use those funds in a different way? I don't see why you would not agree with that.
Yeah.
Good suggestion.
There's tons of areas we can improve, that's for sure.
Yep, absolutely. Look at the gun registry and the federal payroll system. Complete failures and massive cost overruns. Insurers may make money, but they are relatively efficient. They still need to be overseen, but they're not as bad as Dave's making out.
Again, I agree. People are agreeing with me here. This is great.
Dave, you picked the wrong side to argue here.
No, not at all. You know what? The more you know about the insurance companies and the more you find out about how they're paying claims, the more inefficiencies you do see. And I mean, it does start to skew your view of things. So, but I just see so many areas where this could be just done so much better. And I agree. If we were talking about building a new pharmacare model for distribution, I would agree 100%. But we're not. What we're actually talking about is using the existing model that's out there right now and just tweaking it. So if you think about it, the simple example of Ontario, if you take the ODBH test off, you now have 4,400 drugs for every Ontario resident. Simple, done. and there's nothing to it. I mean, I'm oversimplifying, obviously, but it's not building a system. It's not creating a whole new thing. It's utilizing the services and processes that are out there that the ministry has been running for decades.
Yeah, absolutely. We have a point on here that the only way that National Pharmacare is going to be a success is if there's a health tax placed on employers. Do we think employers are ready for that?
Well, Jeremy
Well,
brought that point up about as a tax break and stuff, and it could be that that's a way to go, but why are we having societal's cost put on a small subsection of employers? I mean,
yeah,
if that's the case, I think what you'll end up doing is just pushing more employers to hire contract staff without benefits and
exactly.
stuff like that, at all, and trying to kind of avoid um, people being on their payrolls. And
Yep.
again, I'm just talking about Ontario, but Ontario's health tax is based on payroll premium. It's not, or sorry, payroll cost. It's not based on expense. So if you have 50% of your people are subcontractors billing for their time, you don't get taxed on that. So I really think it has to be a general revenue shared by everybody and make this really universal. I don't think it can work on an employer health tax. And
No,
they
if
tried that
you're,
in New Brunswick and it failed before it
yeah,
even got out of the can.
yeah, yeah.
Absolutely. So there's a statement on here as well that says Green Shield, Blue Cross, and the cooperators are all their own pharmacare managers, and they're doing everything in-house. Their systems are solid and they're efficient. Would you
No, they're
agree?
not. No, not at all.
I wouldn't agree that they're completely efficient. No, they
No.
can definitely be better. I think
I've, yeah, go
Sure,
ahead,
go ahead.
Jeremy.
I was just going to say, I think they're doing their best, and I certainly think that the in-house PBM has its advantages. That said, I don't think it's as efficient or effective as it could be, let alone the systems that are outdated.
Yeah, Green Shield and Medivy do have some really good systems and processes and stuff. I'll give them that. Cooperators actually does use an external PBM that they're involved with, but which I'm not as supportive of. But I still come down to the same question. My learning of the Trillium integration issue, Green Shield and Medivy Blue Cross do not integrate the way that it was intended to this day. So they do a great job, and I'm not taking away from what they do or anybody does, but they're still leaving, 100 million plus sitting in coming out of our employer's pocket that was never intended to be paid for by the employer.
Right. Yeah. Will their compensation increase to account for the fact that their net income will be lower if they don't have the added benefits of their workplace benefits plan? So I'm assuming they're talking
Oh
about
yeah.
advisors.
No.
No.
I think the way it is will the employees be compensated because we take
Oh, right.
benefits out of their plan? So we're
Mm,
taking a financial positive to them out. And I would say 50% of small businesses still don't have a benefit plan.
yeah,
So, are they in any worse shape? I don't think most employers will, although I will admit, I've said to employers, rather than enhance your plan because you've had a great year, just give people bonuses, because you're not going to be tied into it forever. So, you might see some employers give a little bit back, but I'm with Jeremy on this one. It's not going to be dollar for dollar cut and
no,
give it back again by any stretch.
no. You would
Right.
hope there would be some increase in benefits because of the savings, but again, I just don't see it being dollar for dollar.
Yeah.
Right. And how do you see this impacting BC where pharmacare already exists?
Big sigh.
Yeah,
Um, so, so bottom line is, BC and Quebec and stuff that has a different style with RAMQ. Could it help? Yes. Will it make a difference? No, I honestly think that the pharmacare model would work through and basically be kind of, I don't know, not overlapping, but um,
supplementary too.
supplementary to, yeah.
Yeah,
So it's
yeah,
just going to say, okay, does a BC Pharmacare model and formulary and everything match up what we're trying to deliver? Okay, we're done. Like it
yeah,
may be somewhere like BC probably has the least amount of work to do other than just formulary touching and stuff. And they've been
yeah.
pretty cutting edge on their biosimilar policy and stuff like that too. So I mean, they're paying attention to what they're doing. They're one of the few areas. Most of the other insurers are not anywhere near there. So there's a good example of the province kind of jumping ahead of the private side and being more efficient and effective earlier.
Yeah. And I think if this is to go forward, BC would be the model that most other provinces would have to look to right now. They got a lot less work to do than anybody else, from what I understand.
Yeah, maybe, yeah.
Do you think that the new PMPRB pricing model is good, but should have applied not only on a go-forward basis, but be applied to all scripts, including existing ones?
Oh, that's a fantastic question.
We can thank Jody for that.
Jody, yeah, good one. When I sat in on the PMPRB person speaking on this at a recent TELUS conference, that was the one big question of where's this going to go? Is it going to be go forward, or is it going to be retroactive to repricing all drugs? And boy, if it had gone backward, that would have been a huge savings. But I mean, it would have just raised so many problems and questions. I don't think anybody wanted to make it that political. That said, even if it's just on a go forward basis, I think there is enough new drugs coming in that are skewing the market, like especially biologic specialty drugs and stuff,
Yeah.
that it will have an effect, but it'll take a few years to really see it.
Yeah, I agree. It'll work through, especially with the prices of, like you're saying, the biologics and the specialties. That's what's really driving it on the back end. And yeah, it'll work its way through. But to go retroactively is kind of dangerous.
So rather than a national pharmacare program run by a federal agency, what about the feds assuming the role and assume the risk of CDIPC, offload these rising pooling costs from the employer healthcare premiums?
Yeah, so that was one thing that's been brought up by several different groups of why not have a federal pooling program, and whether it's the CDIPC pool or something hopefully a little bit better than that. I think that is a solution, and if we were going to go Jeremy's way and say let's have a hybrid of some national and some provincially delivered and some privately delivered, I think that taking the pooling for high cost claims out of the employer, insurer, and private citizens' hands and putting it in the federal government might be a cool way to do it. You still have the constitutional issues that Mike brought up of, whose job is it anyway, but I think everybody would be fairly comfortable putting it into a federal pool.
Mm-hmm.
And we have another question here. Why are drug prices higher in Ontario compared to other provinces?
Dave, you want to take that one?
I don't
don't
know.
really have a good answer for you.
I honestly, I don't know. Like, I mean,
Yeah.
I don't have a good answer for that.
Quebec is higher than us, and I don't know. I mean, I kind of know how the pricing works, and honestly, off the top of my head, I haven't got I don't have an answer. I'd have to go and think about it. But yeah, I don't know.
Okay. And is the ODB only for people 65 plus, or is it also available to people on welfare?
Oh, so yeah, so the ODB formulary is open to not just people on, it's not called welfare anymore, but work, whatever it's called, I can't think of the name. No. Oh, yeah, no, but I mean, it's for people on ODSP with disabilities.
Mm-hmm.
It's on the Trillium program uses the ODB formulary and the EAP formulary, and people on whatever it's called, what Ontario Welfare or whatever. It works for all those programs. So it's not just seniors, it's beyond, but seniors make up the majority of the cost.
Okay. Here's an interesting suggestion. For a national pharmacare program, should employers pay a certain percent of the costs, given they will experience savings with not being responsible for their employee drug costs? So should employers still have to contribute to this program?
No.
No.
Is
I
that
don't
too
think
easy?
so.
Yeah.
It's
Okay.
a societal cost. How is this an employer cost?
Yeah.
Like
We're
I could
removing
maybe
it from the employers, putting a tax on employers is just, it doesn't make sense. Yeah.
So if we were going to go US style, and I'm not suggesting that, US plans cover their employees and the employees pay for dependent coverage. So if you went that model, you could kind of go, okay, well, the employer is benefiting from the employee working for your company, and here's a way to provide tax-free compensation. There's a definite financial plus for that. But if you're going to tax back and stuff, I don't see the point. And sorry, the name I was looking for was Ontario Works Program. That's the name of the welfare. Sorry.
Yep.
Right. If a two-tier system emerges, what do you think the best model is to take the pressure off of small businesses with high-cost drug claims? We've got another sigh, Dave.
Yeah, you got two
Jeremy,
sides
I
there
think
at
I
the same
heard one
time.
from you too. Yeah.
Yeah.
Yeah,
Um, I don't know if there's any one best model. I think if you if you leave it two tier, I think definitely taking the high cost specialty, the really risky side out would
yeah,
definitely help. I mean, if we just oversimplified everything, and this is not on the table or anything, but if we just said, okay, the private payers are going to pay up to $10,000, and any drugs over 10,000 are going to be
yeah,
paid through an industry pool that is federally managed or whatever, I think that would probably give real stability to
yeah,
rates for employers, put the risk of, and risk management in a federal level and stuff, and you'd end up with removing the stop loss rates, which are a profit center for insurance
yeah,
companies.
yeah.
Okay.
Okay, we're agreeing on everything. This
I
isn't more.
know, I know we're agreeing
You
way
guys
Yeah,
too much
are.
here. These questions are too directed to
Yeah.
yeah.
Well, you guys did get a comment here that apparently the boys are quite entertaining. So props to both of
Oh,
you there.
Beautiful.
glad to help out.
Thank you.
Yeah.
How to get through a
Um,
Thursday.
there you go. So if there is a concern about advisors losing revenue, which Jeremy, you had mentioned,
Yes,
because they're getting paid on a commission basis, then why
yes.
don't advisors switch to compensation based on a fee for service model?
Because
So
advisors are terrified to disclose how much they make.
I would agree that a lot of advisors are. I do think that what you're going to see eventually is a per employee type of model, as
I,
opposed to a percentage of premium type of model.
I agree too. And
I
you're
think
going to
that's on
see
the way.
I think it's going to be a two-step model. So you're going to get paid like, $50 per employee per month for the first year
Yeah,
to pay you for implementation, and then, $25 per
yeah,
employee per month thereafter for service. I
yeah,
agree. I think we'll get there. And I think people are just not, I mean, G19 for whatever it was would have kind of brought around disclosure. Yeah, don't
yeah.
get me started.
Don't
But
even start with
yeah,
that.
but I mean, I think that if advisors aren't out there disclosing now, they're going to be in for a rude awakening one day when we get there, and
100%.
whatever
Yeah,
causes that is going to be at
yeah,
their peril. So
absolutely. And just, I mean, personally, I would never buy something when I don't know what I'm paying them for, or if I don't know how much I'm paying them for it. It's
I
just
don't
not
even
going to
want to go
happen.
down this road, so I
Yeah,
won't. Yeah, but
yep. Stop it there.
yeah.
Yeah, there you go. Dave, this question is directed at you.
Okay.
Why should pharmacare be universal and not means tested? Will this not result in the most cost efficient tax burden?
That's a great question. I think because if we're going to use Canadian universal, portable, transportable, like all the accessible and everything stuff, and use Pharmacare to match that, then I think the universality helps. I don't know if the means testing is necessarily the best way to do it. I'm not saying it's not, it doesn't work, um, but it definitely kind of brings up issues. And if you look at some of the means testing provincial programs and how they're set up, 3/4 of the whole process is trying to figure out, what income do you use? What's household income? If you've got students at home or somebody's renting space or sharing, like all that type of stuff, you spend a huge amount of time on it. And I don't want it to get, and here's a point for Jeremy, you don't want the administration to get more bloated to administer the program rather than make it simple. So if I'm making more income, should I have a higher deductible? Yeah, I'm okay with that. I mean, I'd throw it back at you and say, okay, then why don't we do the same thing on group insurance plans? Why don't we have a means test to them or a deductible that's flexible based on income? I don't think it would fly really well on the private side, but it's not the
I don't think
means
that
is
would.
reasonable.
I don't think that would fly, but I think it's an interesting suggestion, and maybe as an
Yeah.
option in plans to suggest that could be something that would be interesting to some
It
employers.
works. It works for Trillium. It works
Yeah.
for PEI's system is similar and stuff as well. Does that means testing deductible create a financial hardship for people? Yeah, absolutely. But it just but kind of no different than the 20% co-insurance does
Yeah, so
for a
relative.
private plan. Yeah. So yeah, but it could be.
And what are your thoughts on funding for autism and other special needs instead of pharmacare?
I'm sorry, this webinar is only on pharmacare. The next webinar that we do with BBD will be all about other healthcare. I was
There
just
we
joking.
go.
I was just
Okay.
joking.
So go ahead, Dave, feel
I,
strongly
I,
about that then. On to the next question.
no, I thought there was another question about wellness back somewhere earlier too. And I mean, definitely if you, okay, and I know Jeremy won't agree, but if you could cut the 20% out of the cost, then you would end up with lots of dollars to invest in other areas and maybe healthcare, other areas of healthcare wellness and other funding models would be well worth it.
And in an ideal theoretical world, I think that's what would happen. I just unfortunately don't see that happening dollar to
Yeah.
dollar.
No, I agree.
Okay. What type of formulary are you thinking would be most likely under a national program? And how would you handle employees losing coverage for currently covered medications?
Okay, so just as a note, we just passed 3 o'clock, so we appreciate anybody that's hanging around and listening beyond the hour that we'd slotted out of your day. Can I say that, Mel?
Yes, we do. Absolutely. Thank you.
So can we say that one more time? Sorry.
Yep, absolutely.
What happens with employees who lose coverage when they go to a pharmacy program?
Right. And what type of formulary are you thinking would be adopted by a national program?
So that's wide open. If we're talking about the end, I think it was around 6,000 drugs, which would put it somewhere between Ontario's 4,400 on the ODB formulary and Quebec's 8,200 or 8,300 on theirs. So
Yeah.
pretty good. Losing coverage for currently covered medications, I would say, is the same risk if you change employers and they have drug caps or they have formularies that don't have it, or you move to an employer that doesn't have it, or you lose your job. There's bottom line is there's going to be situations where people aren't covered for all medications all the time. And yes, it's going to be a hardship. And at the end of the day, that's where the patient support programs from the drug companies and other things are out there. But there's going to be people to lose no matter what we do. People are
And
losing
that's one
right
of my main
now.
concerns with the rollout.
Yeah, yeah. Whether it's happening now, whether it happens then, there's always going to be people that either don't have access to the drugs they want or can't afford them or whatever.
Right. Yeah. We've got about a handful of questions left here as long as we don't have any more entered. So the next one is this is to Dave, why can't PMPRB not just be expanded to include all stakeholders to negotiate for everyone? This would accomplish the goal of reducing drug prices without creating a new tax burden or eliminating private sector revenues and jobs.
Yeah, so I mean, I can't tell the federal government how to do their job, but the provincial government basically allowed two-tier pricing with private and public and stuff to be different. So that's kind of created a problem at a provincial level that a federal level doesn't change. And all we're talking about is they're setting the price kind of just coming in that potentially can be and is for everybody. Like that's just the entry level cost coming in. So I mean, if there's a savings through PMPRB negotiation on price listing and stuff, it would affect everybody positively, I think.
And Dave, what is wrong with how RAMQ works? Could this model not be expanded and tweaked to work across the entire country to solve the issue without creating a new tax burden or eliminate private sector revenues and jobs?
Absolutely. So could BC Pharmacare. Like, I mean, it's not perfect, but absolutely you could do that. And that's why I'm saying these models already exist. We're not rebuilding the wheel. Like, I mean, they're already out there.
Right, absolutely. We have another question here, and it's back to the funding of National Pharmacare, which I know we've touched on quite a bit, but I'll go ahead and read the question in case there's anything else you'd like to add. Funding is going to be a big concern for National Pharmacare. Taxpayers will be paying an additional premium. However, the government will also look to subsidize a portion. Most likely, the subsidy dollars will come from the health transfer to each province. If the government lowers the health transfer, this means BC will get less funding for other health items such as hospitals and so forth. The province that will benefit the most is Ontario, as the population in Ontario is the highest users of drugs. How do we make it fair for all provinces and all taxpayers?
That's simple. We don't. It never has been. It never will be. We've always had, with transfer payments, have and have not provinces. The fact that Ontario's the larger user and stuff like that, is an issue. But I mean, it's never going to be balanced. It's never going to be fair.
Whenever you're spreading risk across a group, you're going to have those that are overusing, those that are underusing, utilizing, and that's how it balances out.
And disadvantaged. I mean, right now, BC citizens, residents, have much better access to healthcare than Ontario ones. How is that fair? So is it going to shift now the other way and disincent them and incent us or whatever? Yeah, there's going to be that constant ebb and flow. And unfortunately, the federal government through transfer payments and everything else try and kind of keep that balanced, but it's not going to be balanced. Unfortunately, it's never going to be fair for everybody. But what is going to be fair is if you move from BC to Ontario, you're not going to all of a sudden lose coverage or start to take on a financial burden that you would prior to Pharmacare. That's the part that will be a positive out of the whole thing.
Yeah.
And last question here, just to wrap things up. On a purely economic basis, can economies of scale and return be achieved by providing drugs for millions versus thousands?
100% yes.
Theoretically, yes.
Yeah.
Yeah. I mean, yeah. It takes less to administer that whole program for 1 million people than for 10. That's.
Oh yeah. You don't have to have different profit margins for different companies, some that are efficient in delivery. And Jeremy's right, and whoever was posing the question about, somebody like Green Shield that's got a much tighter adjudication philosophy than maybe another insurer. It's you put scale together and you can do things, and it doesn't have to be the expense of the drug companies. It's not like you should go and negotiate everything down to the pennies or anything like that. Just pure economically speaking, economies of scale can do some great things.
Yep,
absolutely. So that's all of our questions. A couple comments here just around disclosure. Some of our advisors have stated that they do disclose their commissions, but they do also agree with the comments you guys made around that.
Yeah. Thank you. I'm
so
glad you
I'd like.
Keep it up.
Yeah, I know a lot of people do disclose. Hopefully everybody will, but.
Absolutely. So I'd like to say a big thank you to both of our speakers, Dave and Jeremy, for this fantastic discussion on a very timely and interesting topic.
And thanks
if you
for
have
the 100
any
people
further
that
questions
hung on.
Yeah, absolutely. We've still got quite a few attendees that hung on past 3, which is great.
Thanks so much, everybody.
If you have any further questions about National Pharmacare or would like to do some additional reading, I encourage you to keep an eye out for the Benefits by Design blog located on our website. We publish a new post weekly on Tuesdays, and we have a good summary of the main points of the issue coming out next Tuesday. You can check that out at www.bbd.ca/blog, as well as a bunch of other topics. So thanks again, everyone, for joining us, and I hope everyone has a great rest of their day.
Thank you.
Thanks, everyone.